Hi there. I'm Dr. Barry Bertolet. I'm an interventional cardiologist from Tupelo, Mississippi. A little bit about what we're talking about today has to do with DyeVert and the use of this technology within our Cath Lab in order to lower our risk of contrast-induced nephropathy. Our hospital is known as the largest rural hospital in America. We're in Tupelo, Mississippi, which is in North Mississippi, and despite being in that rural setting, we are a two-time Baldrige Award winner, which is the United States Congress Award for Quality. Additionally, this year we were reported as the IBM Top 50 Cardiovascular Hospital. Now, unfortunately, within our state, cardiovascular disease is quite prevalent. We do see that there are a lot of people that have multiple risk factors, and with that, we do have a high-risk population for contrast-induced nephropathy. Particularly, we have a high-risk population of diabetic patients. When we were looking at our contrast-induced nephropathy issue, we looked at several different problems that we were facing at the time. One is that the American College of Cardiology had recommended a pre-hydration strategy. We would bring patients in the night before, hydrate them overnight, and then perform their cardiac cath procedure. We learned later that Medicare or CMS and a lot of other insurance agencies were not paying for that overnight hydration. They represented that as being part of the procedure, and that was a cost loss to our hospital facility. Additionally, we also found that a lot of the doctors were not recognizing patients to be at risk for contrast-induced nephropathy ahead of time, and were not scheduling those patients to come in for prehydration. So despite our best efforts, we were seeing a contrast-induced nephropathy rate of about 6.3%, which in a facility and in a culture where we were looking at quality is that this was a concern for us. In response to that, we developed a multidiscipline group in which we looked at different avenues in which we could improve our outcomes with regard to contrast-induced nephropathy. We wanted to make sure that we screened appropriately for those at-risk patients, particularly looking for those that had a GFR less than 60. We wanted to make sure that patients were adequately hydrated, and then we wanted to try to minimize our contrast load, and in particular, we needed to give real-time feedback to the physician at how much contrast was being utilized. When we also looked about how much contrast that we should be giving, we actually looked at the literature. And we actually reviewed with great interest Dr. Gurm's article that was published in JACC in 2011. And with that, we developed, based on his data, a threshold, that is the 1.5 times the GFR would be our maximum contrast load that we would use for that patient. In order to achieve that, that was an ambitious goal, but that is where the DyeVert technology stood out. We were able to perform adequate angiograms as well as at a much reduced dye load. And in fact, when we looked at our contrast use, there was a 40% decrease in our dye administration per shot when we used the DyeVert with the same degree of visualization of blood vessels. So with this, we developed our own kidney care protocol. So instead of bringing the patients in the night before, we would bring them in the morning of their procedure, and they would be hydrated from anywhere from 2 to 4 hours, usually receiving 100 cc's of saline per hour, unless they had heart failure, and then there would be 50 cc's of saline per hour infusion. They would receive that pre-procedure. We would then conduct the cardiac cath procedure utilizing the goals that we had set. That is the 1.5 times the GFR for our total contrast use. The DyeVert technology allows us to look at a screen and then see exactly how much of the contrast that we have used. We tried to make our physicians stay true to that goal. And then after the procedure, then we would hydrate people for a 3-hour time window, and then we would allow them to go home. In order to make sure that we did not miss anyone that had at risk for contrast-induced nephropathy, we then turned to our Cath Lab staff, and we asked them to do a GFR calculation on their cell phones of every patient that we were bringing into the Cath Lab. And with this, they would automatically then use the DyeVert technology. This allowed us to move away from having the physician look at the lab, calculate the creatinine clearance, and determine this person was high risk. The Cath Lab staff then could see this creatinine at the time of admission to our observation unit, begin the hydration protocol, understand in advance that we would be using the DyeVert technology, and then they would already have the goal calculated and entered into the DyeVert computer monitor when we arrived into the Cath Lab. When we followed this protocol, we did look at our patients, and we've reviewed now our first 100 patients. In our first 100 patients, 72% of these were men. The average age was 68. 60% of these people were diabetic, with 78% having a degree of hypertension, and 45 milliliters per minute was our estimated creatinine clearance for the majority of these people. 98% of our patients were able to have their cardiac cath procedure adequately conducted using the 1.5 times GFR amount of contrast. The average Moran risk score was 7.9 with an estimated contrast-induced nephropathy rate based on this scoring of 14%. When we reviewed those 100 patients, our contrast-induced nephropathy rate was 0. So with this, we believe that we have hit a home run when it comes to prevention of contrast-induced nephropathy. When we reviewed the cost-benefit of deploying the DyeVert technology within our own hospital system, we found that our hospital cost per patient admitted overnight was $100 an hour. If we brought them in and hydrated them overnight for 14 hours pre-procedure, that was a cost of $1,400. When we looked at the institutional cost of the DyeVert technology, for us it was around $300. And so if we look at that difference, if we say now we can avoid that overnight hydration, we're looking at a net benefit to our institution of $1,100. On the flip side, when we look at the reduction in contrast-induced nephropathy, we took our contrast-induced nephropathy rate of 6.3% and essentially took it to 0. The estimated cost of a contrast-induced nephropathy is $15,000 per patient. So that would mean that our cost in that scenario for 100 patients would be $94,500. If we break that down to just that individual basis, we are looking now at a cost of $945 per patient that is at risk for contrast-induced nephropathy. So if we look at those two numbers, if we're looking at an $1,100 net benefit by not admitting the patient overnight for hydration, and then we're looking at a $900 benefit because we are not spending that money to take care of an acute kidney injury event, that ends up being a cost benefit of $2,000 per patient. And again, these are the patients that are at risk for that acute kidney injury. When we tracked our acute kidney injury rate, we used the Cath PCI registry. We maintained this registry both pre-deployment of the DyeVert protocol as well as post-deployment of the DyeVert protocol. This way, we were consistent with our numbers in finding out our cases of acute kidney injury. Right now, we are participants in the Diminish registry, where we're looking not only within our facility, but within a broader group of doctors and hospitals across the United States to see, does this theory hold true? And with that, we hope to show that with the DyeVert technology and being able to lower the amount of contrast that we need to administer during a heart cath procedure, as well as keep it at count of how much dye that we have administered, will help lower the contrast-induced nephropathy risk that we see. Unfortunately, when a patient does develop a contrast-induced nephropathy, we know that this increases their length of stay in hospital, we know that this increases death, and we know that this increases their risk of bleeding complications. And so that means higher cost. And so this is a big problem, particularly now as we move into this COVID environment, is that patients don't want to be in the hospital. We need to shorten our length of stay or not admit them into the hospital at all. We don't need to have patients being readmitted into hospital because we've caused a complication. And so this technology at this time, we believe, is critical in our practice of cardiology to not only do heart cath safe, but also to protect the patients from, and hospitals, from other risk as we move forward in this particular environment. So in summary, we have found that when we use this hard stop, having the Cath Lab team calculate the GFR and automatically deploy this protocol has been very, very effective for us in capturing these patients that are at risk for contrast-induced nephropathy. The next frontier has been the Stemi patient. When these patients arrive into the hospital, you don't know their lab. All you know is they're hurting and they have an abnormal EKG. So we assume that all of these patients are at risk for contrast-induced nephropathy. Now that we have had many, many patients go through our Cath Lab, the setup for the DyeVert is very simple for our Cath Lab staff. Usually by the time that I've achieved access, they have already set up the DyeVert equipment, and then the procedure can continue without delay. But we believe in these Stemi patients that the use of the DyeVert technology can lower the contrast load and lower a future possible risk of contrast-induced nephropathy in this vulnerable population. Finally, if I were to give any advice to anyone wanting to implement this protocol in your hospital, is I would recommend this. Start with a basic protocol. Again, we believe ours was a very good protocol for our institution, bringing patients in to our observation area, hydrating them for a number of hours, have the Cath Lab staff automatically calculate the GFR and deploy the DyeVert technology as needed. We found that taking this out of the hands of the physician actually worked better because in an automated protocol is that we missed no one. And with this, we were able to deploy the DyeVert appropriately in these at-risk patients. Thank you for attending.